You know what's cool? We're getting emails from all over the world. I feel like the podcast, Dr. Cooper, has really struck a nerve, has really tapped into something that people really are interested in.
Yeah, I'm so excited to hear from people from other countries because I'm always curious what's going on over there. What are people thinking? So this has been fantastic.
And it speaks to the universality of the condition. You know, we're all humans. We're all struggling with this stuff. Mm-hmm. What I find really exciting, though, is when somebody engages on all this stuff and starts using some of the same terminology that Dr. Cooper has raised in terms of...
Isn't that crazy?
Yeah, it's really cool because it speaks to, they're really getting it. They're really understanding the medical concepts behind this whole discussion. It's not about reducing calories. It's not about dieting. It's not about fasting. It's about your metabolic system. Well, should we jump into the mailbag?
Sure.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. Good to see you two.
Hello.
Hi. Hello.
All right. These are some of my favorite episodes. We're going back into the mailbag. And the mailbag is getting pretty full, honestly, you two, because people from all over the world are sending in questions and comments and kudos and sometimes criticism, which is fine too. But if you have a question for the podcast, for Dr. Cooper to answer, info@diabesityyinstitute.org is how you can get a hold of us. All right, let's jump right in. I wanted to start with one, which is just some positive feedback from Rachel. Rachel said, "Hello, I wanted to thank you from the bottom of my heart, Mark, Andrea, and Dr. Cooper for the podcast. I've gained a large amount of weight in a short time, likely insulin resistance due to genetic influence." See, I mean, these people are getting this. You can tell just from the way that they're describing. She said it was exacerbated by major stress and hormonal changes, in quotes, pregnancy. "I've started working with my doc to treat metabolic issues, but cannot thank you enough for all the info and support on the journey. I feel so armed with information, and it's such a great podcast. My mind has been blown." And Rachel, thank you so much, first of all, for listening. But Dr. Cooper, I feel like this is one of the major goals of the podcast, and that is to equip people with a vocabulary and an understanding that they can then take to their provider, right?
Absolutely. It's definitely true. It's so great to hear that. And that's definitely our hope, is that it helps have that conversation with your provider and maybe push back against some things that you know in your heart are not going to help you. We're hoping to provide that science behind it so that you have a better language when you're in that situation.
It's like a little toolkit that you can bring with you to the doctor. You have like some good words that, honestly, when you have a lot of these phrases and a lot of these things, it makes your doctor, your nurse practitioner or whatever, it raises first of all, it makes them think you're really smart. And it makes them think about looking at your situation a little bit differently and a little bit more intensely, that they need to pay attention a little bit more. And I think it's fantastic.
All right. Rachel, thank you so much.
This one's from Patricia. And she says, "Hi, Dr. Cooper et al. I was treated for breast cancer in 2012 with surgery, chemo, and radiation. Although I was close to menopause, being age 52, the chemotherapy finished my menstruation abruptly. I was wondering if this cancer treatment affected my metabolism and is part of the reason I gain weight extremely easily now and struggle to lose it. Obviously, the life-saving treatment was worth it, but I'm curious all the same and frustrated about my weight. Thanks, Patricia in Toronto."
Well, thanks for that question, Patricia. Thanks for listening to the podcast. This is a great question. And we do see a lot of patients post chemo and radiation who have undergone cancer treatments of various types and developed abnormal metabolic changes after that. And it is known that many medications used in chemotherapy impact the metabolic system. So, yes, I think there's a very good chance that the chemotherapy did do something to create what we call those glitches in the metabolic pathway, but you should have hope that can be reversed once you're done with the treatment. Often, unfortunately, like most medications that disrupt the metabolic system, they act as like a hit and run. So it does some damage there, and unfortunately, it doesn't just reverse on its own back to normal afterwards. So you do need to do a full metabolic workup, see what's going on with your insulin levels, your glucose levels. Obviously, if the chemo, part of it affected your reproductive hormones, that affects your ability to hold on to your lean mass, including bone and muscle and all of that. So I think a comprehensive program looking at where you are now, looking at your lab work and looking at body composition if possible, just to see, whether your lean mass is deficient. And then you might need to incorporate a strength program and some kind of pharmacotherapy from the metabolic side of things to help reverse some of the damage that the chemo may have created. But as you said, it was well worth it because sometimes we have to do these things. I've had patients that say, well, I was diagnosed with breast cancer and now I've got to go through this chemo, but what's it going to do to my metabolism? Or other patients with psychiatric issues that have to be put on certain medication that's very helpful psychiatrically, but can impact their metabolism. But my philosophy is you just need to treat those things because they're so critical and they affect you so much and it's so high risk not to. So if you've got to go through that chemotherapy, you've just got to do it. And then afterwards, try to pick up the pieces by looking further into the metabolic system. And same thing when it comes to the psychiatric meds. If they're keeping you balanced psychiatrically, you just need a counterbalance from the metabolic side of something that's going to help prevent the destruction that they do to the metabolic system. And the great thing is it's possible to do for most people. For most people, this is very possible. But I think definitely post-cancer treatment, there's so many factors because the stress of it, too, affects the metabolic system, the stress you're going through. That affects a lot of metabolic factors. There can be pain involved at times. With some chemo creates like a neuropathy type of symptoms. And so there can be pain, and pain affects the metabolic pathway, too. And then there's just the drug effects of the chemo. So there's a lot that could happen. And so I just encourage you to try to find someone who specializes more in metabolism that could look at where you are now and see what they could do to help support your system to get you back to kind of a balanced baseline.
Okay. Patricia, thank you so much for listening and for the question. Here's a question that goes back to the last episode that we just did on PCOS. This is from Katie. Katie says, thanks so much for the Fat Science podcast. I want to ask about GLP-1s and trying to conceive. For background, I'm a woman in my 30s, and after trying to conceive with my partner in 2021, I was diagnosed with PCOS. We decided to stop trying while I tried to regulate my hormones and ovulation with metformin, diet, exercise, and reducing stress. Being prescribed to just reduce stress is just as annoying as being told to just lose weight, in quotes, by doctors. But she says after 2 years of hard work, my weight and my blood work were almost exactly the same as when I started. I was obese at 240 pounds, 5 feet 10. My insulin, A1C, and cholesterol were high. Frustrated, my doctor prescribed Zepbound, and I started taking it in August of 2023. In 5 months, I've lost 40 pounds. My blood work has completely transformed. I'm now on my last shot with the intention of trying to start to conceive in the spring after a few months of not being on GLP-1. The quandary, though, is this, Dr. Cooper. I've loved being on Zepbound. Life without food noise is transformational. I have so much more energy. I'm hopeful, in control. Though we want to get pregnant and start our family, I'm mourning the end of my GLP-1 journey. Do you have any insight or advice for me and other people who need to get off GLP-1s for pregnancy. What does maintenance look like during pregnancy? Do you think that there will ever be a metabolic drug that is safe for pregnancy and breastfeeding at the same time? So what is the research looking like for people who want to get pregnant while on the GLP-1s? Thank you so much again for the podcast. Katie, thanks for the question. Wow, there's a lot there, Dr. Cooper, but so many of the same common themes.
This is such a great question, and it's so well stated. You know, this is something we deal with a lot because we do get referrals from reproductive endocrinologists for patients of theirs who have infertility, that they are looking to see if there's a metabolic basis. And then just like with this story, the GLP-1s, or in this case, it was tirzepatide, which is that combination GLP-1 and GIP, made such an enormous difference in the overall metabolic health. And one of the concerns is that if they do have a long half-life, and right now it's not really known if they're safe or not. It's not that they're not safe, it's just not known if they haven't been tested. There right now is an ongoing observational kind of study going for people with full-blown diabetes that have needed to stay on the GLP-1 during pregnancy. And so they're hoping to gather more information from that. But in the meantime, it's not recommended for people to stay on GLP-1s during pregnancy, just because it may be a risk that's not worth taking until there's more known. But one of the big concerns is that conception may be much more difficult without being on the GLP-1. So here you go through this washout period where you're getting it out of your system, and then you get to spring where it's time to try to conceive, and you can't conceive because now you're not on the medication that was supporting your metabolism, that was improving your fertility, and that's now gone out of your system. Because it's not really that just losing the weight is going to restore your fertility. The weight, again, is a symptom. It's not the cause of the problem. And so the tirzepatide is sending a signal to the brain that says, hey, we have enough food supply, and all through the metabolic pathway, that restores metabolic health through that pathway, and part of it is your fertility that it's restoring. And it's pretty much independent of the weight loss, really. And so my fear would be as you're off of that medicine, it's probably your same fear, as you're off of that medicine, your metabolic system will start to kind of go backwards again. And that will lead to more difficulty becoming pregnant in the spring. So it's a tough problem. So one thing to consider, I don't know if your provider would be open to this or not, and I don't know if it's the right thing to do or not for you, but one thing you could discuss with your provider is that there are some GLP-1 meds that have a much shorter half-life than the one that you're taking. So the weekly medications have a very long half-life. So it takes about 6 weeks for them to get out of your system, basically. And so if the goal is we don't want any of it in your system by the time you start becoming pregnant, then you would have to get off of it quite a long time beforehand, especially if you were trying to really not have any of it in at the time of conception. So one option would potentially be to switch it to a daily medication. The daily ones, their half-life is a matter of hours. And so they are out of your system within days instead of multiple weeks. And so if that's an option, there are 2 daily GLP-1s on the market right now. And one is the oral form of semaglutide, which is marketed as Rybelsus. The other one is liraglutide, which is a daily injection. And so that was the same as Saxenda. And different OBs have different feelings about this, but that is definitely, there's a good argument for whether that would be an acceptable alternative. Now, you still, so that way, even though you would be stopping the one medication, by having the other one there in the background as your tirzepatide is wearing off, even, starting with a very low dose and then having that in there, and then the amount of time you'd have to stop before conception is very short. You just work out what the drug half-life is, and there are drug half-life calculators that are very handy that could tell you exactly, how long it would take for that drug to be out of your system, but it'll be a fraction of the time that the weekly ones take. So that's just the dilemma, because it's not that these drugs, are just in there for weight loss. I mean, they actually improve your chances of fertility. So that's the concern. If they're going to rely on a medicine, I always think of it to not use a medicine to improve fertility. If that medicine would have to be stopped long before the time of conception, choose a different medicine that you would be able to continue longer so that you're not losing the strength of the fertility that you gained in that period of time. Because there are several medicines that might be used that you wouldn't want to take during pregnancy. So it'd be good to steer clear of those and go on to something that might be more acceptable.
Always remember that they shouldn't be called weight loss medicines. They should be called metabolic medicines or metabolic medications. It's like when you call them weight loss medications, it just further goes down that path that they're temporary things that you just take to lose your last 5 pounds or whatever. But they're so much bigger than that.
Yeah. Katie, that was a great question. Great answer, Dr. Cooper.
All right, now we have one from CJ. Good morning, Dr. Cooper. I have a question for your Fat Science podcast. I know you've done the topic of supplements before, but I have a specific question about iodine in the American diet. Since many people have switched to kosher salt and other trendy salts, many of the seasonings and foods we eat now lack the nutrient iodine. I read an article about this and how iodine affects metabolism and is linked with weight loss in patients with obesity when they are put on an iodine supplement to bring their daily iodine levels to normal. Would you recommend that GLP-1 patients check to see if they are iodine deficient? And if they are, should they use an iodine supplement, and what should they take? If it helps, then she includes an iodine reference. She said, thanks, a fan and a listener from Tampa.
Aw, that's a great question, too. And it's so overlooked in medicine right now. And partly because we've been spoiled because we were using supplemented salt for years that was supplemented with iodide. And so we didn't really have an iodine deficiency in our population. But it's true that with the onset of the, quote, trendy salts, as this person's pointing out.
Sea salt.
Yeah, that we are really veering away from the iodine supplementation. And even in processed foods, the salt that's used is not iodized salt.
Oh, I never thought about that.
Yeah, it really isn't. And
So why is iodine important?
that's a very good question, because iodine's so important for our thyroid hormone function.
Oh.
In fact, with our thyroid hormone, as we kind of described in prior episodes, the signals from the brain tell your thyroid to produce a hormone called T4, thyroxine. And your thyroid needs the iodine to manufacture the T4.
Oh.
And so one of the symptoms of iodine deficiency would be if you have kind of a little bit of an elevated TSH, which is the stimulating from the brain, but your thyroid output of T4 is low. Then it's very good to check your iodine levels, because it could be that you have a thyroid problem, but it could also be you have an iodine deficiency.
Oh.
So iodine's an easy blood test. It's, you can order it very easily. It's also,
That TSH test, we do that every couple of months, right?
yeah, that's your thyroid, but then adding on just iodine level, that's also a very good test, and it's very reliable. And iodine's a nutrient that's very easy to absorb from food, so it's not hard to absorb it. So if you're not using iodized salt, and you don't live by the sea, you might have a deficiency. So it's good to check that out. But foods that are rich in iodine would be seaweed. And so if you like sushi or seaweed snacks, you're probably getting enough iodine there. And any kind of shellfish has quite a bit of iodine too. So iodized salt is really a standard way to get it, because anyone who uses salt normally, the iodine that's in there is sufficient. The only issue is, and I hate to get off on this negative, but our salt supply is now found to be really contaminated with microplastics.
From the sea. Yes.
Yes, and also from the processing of the salt. Some of it is from the processing. So it's frustrating. It's
Even
very
so the sea salt is contaminated with stuff from the sea.
the sea salt is, but I think they also say that the processing of salt to make it grind it like
Salty.
that, that also causes some plastics to occur in there too. And I'm not sure if there are other probable contaminants to watch out for. So if you can kind of do a little research on your salt source, it's probably a good idea.
Or the easy fix
Yeah.
is
Salt
I
lick.
have iodine drops
Yeah. There you
that
go.
I use daily because this is part of the
Yes.
regimen that you have me on. So I do
That's
5
true.
drops in the morning, and it's tasty.
Yeah.
Is
I mean,
it
that's
really?
true too.
Yeah, it has a little sugar in it, I think, but yeah, that's something that we keep a close eye on.
Wow.
But just find a reputable supplement company before you order the
Yeah.
drops, right?
Well, and also it's not so straight. Like you don't want to start taking iodine drops if you're not having your blood measured, because iodine's another one of those nutrients. If you get too much, it actually impairs your thyroid function.
Right. Like I know that a while ago there were some people who were eating too much sushi and they had bad
Well,
iodine poisoning.
that's why it was so great and handy to have it in our salt or in the food, because then you can't really overdose on it when it's coming from those sources. When you take it as a supplement, you just have to make sure it's the amount prescribed and that your blood levels are being monitored. So that's just one little thing to mention. But try to find a high
Interesting.
quality salt that is iodized.
Very cool. Great question about iodine.
Who knew?
Well, now we're going to go to Germany, and I looked up how to say metabolic dysfunction in German, which I speak a little bit of German, but it's a really long compound noun, so I'm not
Not gonna
going
try?
to try to say it.
on.
But this is from Lisa. I'm not going to butcher German any more than I already do. Lisa wrote a really great, very long email, but with really a lot of great detail about her metabolic journey. Dr. Cooper, I've listened to a lot of episodes of the podcast. It's really great, shed a lot of light on things. Thank you for your tireless commitment to bringing knowledge to the world. It's been super helpful. So I'm going to summarize what Lisa said. She started first dieting, Dr. Cooper, when she was about 12 years old. She was a little chubby. She lost weight and gained weight 7 times in her life, and the latest 2 and 3 years after the diet. I weighed more than before, so she's clearly gone through some weight cycling there. Then I discovered tirzepatide, and it's been prescribed at Enlightenment to have no longer constant food noise in my head. So she apparently was impressed with tirzepatide. So much easier to make the right decisions, but still, if I had just eaten whatever I liked, I probably would have eaten about the calories of maintenance. So she has a lot of weight cycling, Dr. Cooper, but I think that the essence of her question is, how do I lose weight without a calorie deficit? So she's on a GLP-1, but she is having trouble embracing the idea of eating regular, eating enough, and not restricting calories to lose weight. How is this all supposed to work without being in a deficit, losing weight with this medication? Lisa from Germany, thank you so much for a great question.
That's such a great question. And I'm sure so many people wonder because we're so tied to that calorie in, calorie out mentality that we can't get our head around the idea that we don't have to be counting calories. We don't have to be depriving ourselves. That when you strengthen the metabolic system, as these medications can do, that you can eat just normally without that burden, and your metabolic system will kind of do the work. Because think about it, if you do restrict your foods and you're always counting your calories, your metabolic system is going to catch on to that. And it will think that it has to defend itself against your actions. And so that's called the biological weight defense mechanisms or the biological metabolic adaptation. And that's a very powerful force. And so even when you start thinking you're going to count these calories, it kicks into action, this whole defense mechanism. And so what do we mean by the defense mechanism? We mean that then the famine signals increase, which are chemistry in your brain and in your body that says we're in a famine, red alert, don't burn fuel. And the security signals, which are hormones and glucose levels and things in your bloodstream, those weaken. And so they say, uh-oh, we don't have enough fuel, we don't weigh enough, better slow the metabolism down, conserve energy. So you're just putting that in the picture, that energy conservation, every time you do that deprivation. And so by not doing the deprivation and adding your medication that you're on now, that medication is sending a very positive security signal to your brain that says, hey, don't worry about anything. We are not in a deficit. We have enough food supply. And so then it's green lights for your metabolic system. There's no impairment. There's no hindrance to it. And so that's what I'm getting at. We're not trying to get people to eat till they're over full or eat bad foods that aren't healthy. It's not that. Nutrition is an important component of our health. We all want to be, regardless of weight or anything else, just for our health, we want to eat foods that are not highly processed, that don't have chemical additives, that meet all the food groups, and eating consistently throughout the day. But beyond that, you can pick what you want to eat within those parameters. It's just like make sure you don't go too long without eating, make sure you get all those food groups in. And that way, what you're doing is you're preventing the biological adaptation that occurs with dieting, and you're not hindering your metabolism while this medication is sending a signal saying, yep, we're secure. So green lights, you don't have to store abnormal amounts of body fat to protect yourself. You don't have to conserve energy. So I hope that makes sense.
I have 3 words for Lisa. If all her medical things are right, I would say sing that song, Let It Go. Just let it go, let it go. Because it's the mindset that you really have to let go of. Mm-hmm. It's the mindset of, I need to look like a fashion model or like all those girls in the magazines. Because you know what? You're not gonna. That is not gonna happen, probably. You need to change that. It's like, you know what? Maybe you were not meant to look like a size 6 or a size 4 or a size 8, whatever you think that you were supposed to look like. Maybe the size 14 or the size 12 is how you were supposed to look cute. Maybe that's what you're supposed to be and you look really cute. And that's the best you that you can be, and that you look fantastic, and that you are a great you like that. And, go for it. Like, push it. Like, make that your best you. And that could be fantastic. And the other thing is, if you stop thinking that you have to eat a tiny bit, you can let that go. And you can have the best time of your life. I mean, you can eat it all, and you will eat, you will enjoy. And food is fantastic. Food is great. And you can taste it, you can love it, you can be it. And it's like, it's enjoyable once again. And that also contributes to your happiness, and the weight will come off probably slower, not instantly, like when you starved yourself and lost 10 pounds in a week, because then it all came back, and you know it because she says in the thing that she would go on diets and lose all the weight, and then of course it all came back. Mm-hmm. But it'll be slower, and it won't come back. That's the amazing thing with these drugs, because they're working on your metabolism, not just on a weight loss issue.
Yeah. That's such great advice. And also something to consider, Lisa, is that dosing and different types and combinations of GLP-1s are also an important thing to consider. And the regimen that Dr. Cooper has Andrea and me on, I feel like I'm in complete balance all the time. I don't feel like I'm stressing. There's no deficit. No. It's just it's a total balance of how my body perceives food and processes food. So, Lisa, that's such a great question. Mindset is super important. Trust the process. And thanks for listening, Lisa. Ausgezeichnet, as they say in German. Excellent.
Ooh,
Excellent
Mark,
question.
So smart.
Excellent question. Okay. We've gotten several emails from people, Dr. Cooper, from all over the country asking, can you recommend a metabolic expert? Marissa is in the Cincinnati, Ohio area. Are you keeping a list of doctors that I can recommend? The place where I found in Cincinnati. She has a doctor that she loves there, and just wondering if we're compiling a list or can recommend a list. This is such a common question, Dr. Cooper, for those listeners outside the state of Washington.
That would be a dream come true if we had a network of providers across the country at least, or really around the world, that we could recommend. or just as a referral base. And so we are kind of brainstorming some ideas for how we could put together a group like that. But in the meantime, if anyone has providers that they feel like share similar philosophy, because to me, the most important thing is that concept of deprivation diets and dieting and things like that don't really have a place here, and that the medication is really not, as Andrea says, weight loss medicine. It's really more metabolic treatment, metabolic pharmacology that improves our metabolic function. So if you have providers that seem to share similar philosophy, if you could send us just who they are contact-wise, that would be wonderful. And if we have healthcare professionals that are listening to the podcast, and I think healthcare professionals in general, so expanding beyond the physicians base, but including nurse practitioners and physician assistants and dietitians and exercise physiologists and people who work, therapists and psychiatrists, people who work with patients. We would love to know who you are as well, so that we can start building some type of a referral list. It would be fabulous.
Yeah, that would be great. And also, if you're a medical professional who would like to become part of our community, info@diabesityinstitute.org, just send Dr. Cooper a note, and we'd love to develop a dialogue with you to see if this is a good fit. Yeah, we even got an email from Dr. Mark back in Maryland asking if we could refer someone back in that area. So this is a very common question. From the Minneapolis area, Julie asking the same question. So I think the short answer is let's start building our community, and I think that will open up the availability of more professionals for treatment.
Okay, here's one. Can you do an episode on the mental health side effects of these meds? I didn't comfort eat or binge eat before going on Ozempic, and I have only lost 11 pounds, so it's not like my mental health is being affected by people's comments. It just seems like it had negatively affected my dopamine reward system that was perfect before. I need the meds for my blood sugar and weight, though. Help.
That's an interesting question.
Yeah, it is. It's great. I'm so glad to get this one because it highlights that it's not about, like we've talked about in prior episodes, it's not about cravings. This isn't a cravings problem that we're treating. It can be blood sugar related. It can be other metabolic dysfunction. So I think we pointed out that metabolic dysfunction can look like various things. You can have a completely normal appetite. You could have a heightened interest in food and lack of satiety. You could have just a lack of hunger and overly full feelings. And so this is a problem for people who maybe feel like when they start taking these meds, like they had a normal appetite before and they start taking these meds and it's kind of suppressing their appetite so much that it's hard for them to eat now and it's hard for them to enjoy any food. And that can be a problem. And so my advice there is to try to switch your mindset, because obviously it sounds like you really need the medication for your blood sugar, but to switch the mindset to this mechanical eating model where we talk about that, where it's not really based on hunger cues necessarily, because the medication could be interfering with those hunger cues. So instead, it's based on kind of a timer. And so within an hour of waking up in the morning, having breakfast, and then trying to set a mental or a real timer for every few hours while you're awake to alternate your meals, your snacks throughout the day, so that you're eating throughout the day. Even if you can't get a lot in, something that seems like it's palatable. And if you're struggling to figure that out, I really recommend a dietitian to help come up with some practical ideas of what could you eat that meets that criteria, that hits all the food groups, that makes sure you're nourished throughout the day in spite of the fact that you're really just not attracted to eating as much. And so it is an unfortunate thing, and people kind of miss enjoying food when they're having these side effects. And so the other thing to think about is the dose too high? Because if it's really interfering with your ability to stay nourished, it's too high and you want to reduce the dose. Because if you don't eat enough, if it turns out that it's suppressing things so much that you're not eating enough, your weight won't go down anyway very much, because your biologic weight defenses will kick in that we were just talking about. So those will kick in and fight any kind of weight loss. And so I think playing with the dose of the medication as well as what you're eating and when. And there are some tricks like you want to get enough fiber to be on a healthy diet, but too much fiber causes a slowdown of the GI tract and can make you feel too full, overly full, so you can't get enough nutrients in. So that may be something to play with. And also drinking lots of fluids with your meals can aggravate things and cause you to not be able to eat as much. So I would just look at those aspects and see if there's a way that you can make this medication compatible with your life by altering the way you kind of approach the food, at least while you're on this kind of treatment. But if it's too strong and it's really impairing your nutritional status, then it's got to be reduced.
Yeah, I would say the same thing. And sometimes I like mix a protein drink in a shake and stuff because that goes easier down in a small amount and you get a lot of nutrients for that. And just remember that food is fantastic.
Andrea, I love that.
I mean, it is.
I totally agree.
delicious.
And also something to consider, Lynn, there is an adjustment period for some people who get on the GLP-1s
yes.
where it takes the body a while to figure out.
Right.
And sometimes you just feel nauseated for a while until your
Yeah.
body adjusts. But I wanted to just really briefly touch on what she talked about. In her case, she feels like the GLP-1s may be messing with the dopamine reward system. And in fact, this is something that's being studied at Oklahoma State University right now. There may be a connection, researchers believe, between GLP-1 drugs and alcohol use disorder or substance use disorder and addiction, because there has been some anecdotal evidence to suggest that some of the GLP-1s may reduce cravings for things like alcohol and other drugs. So
And other drugs. I was
if
going to
you-
say, I heard about it with people who were on coke and people who were on other drugs, that it really was like not messing with, but like helping the brain say, you don't need drugs.
Yeah, so Lynn, if you're interested, Dr. Kyle Simmons at Oklahoma State University is the one doing this. This is what we believe is the first actual study, double-blind, placebo-controlled study to see if the GLP-1s may have an impact on addiction, it just seems like that could be a huge game changer when it comes to addiction treatment in this country.
There are a lot of observational reports of that. And one thing that's interesting is alcohol is a fuel that our body uses. And so just like we can break down proteins, fats, and carbs, alcohol is another type of fuel source that we can use. And what's interesting, especially hard alcohol, it doesn't require insulin to access the fuel out of it. So some people that do have a lot of dysfunction with their insulin pathway have a physiologic kind of attraction to alcohol as a fuel source because it's immediate energy versus like even more immediate than candy or something.
Wow,
and so,
really?
Yes. And so for many, many years, I've seen a connection there. And so people that feel like they may be having that, even without the GLP-1 meds, if they get onto that regular mechanical eating plan where they're fueling much more consistently through the day, it does tend to curb the alcohol cravings in a lot of people. But I think that we will see anything that's strengthening that metabolic pathway is going to potentially change the way people gravitate to certain things. And the POMC pathway that we've talked about before is kind of in the middle of that brain pathway that we talk about, the melanocortin pathway. There's like a little substation called the POMC, but that's where we manufacture our own drugs. So it's actually, there's something in it called the CART component, and CA stands for cocaine amphetamine. So,
See?
so we are making our own drugs through that pathway all the time. And we make our endorphins through there too. And so that shares, our metabolic pathway is shared with our own like personal feel-good chemistry manufacturing stations in our brain. So anything we do that improves our metabolic function and drives more of the energy towards our metabolic system when it goes through the pathway, that probably would end up reducing some of the cravings for some of what we call exogenous outside chemistry coming in. And I have had numerous patients who also report that anecdotally.
Wow. It's really going to be interesting to see as GLP-1s are more universally prescribed and used, just how many different beneficial effects there may be to these GLP-1s. It's really mind-boggling when you start to look at the things that are being reported.
I think it's opened up a whole new ball game for different things that it can cure and help. It's amazing.
And I think that we shouldn't miss the fact that it's not just GLP-1s that do this. Because the point is, anything that strengthens your metabolic system is going to have similar results, because our metabolic system influences all of our other body systems. And so if we have dysfunction in our metabolic pathway, it could be causing impairments in all those different areas. So that's why it seems so overwhelming. Like, how can the GLP-1 do this in our kidneys, this in our heart, this in our... But if you think of it more that anything that's strengthening our metabolic system and making our metabolism healthier is making our entire body healthier. And so whether it's the GLP-1 or it's somebody who used to diet a lot and they stopped and now they're eating regularly and getting better sleep, or if it's somebody who's using a different pharmacology that strengthens their metabolism, I think you're going to start seeing it's not really unique to the specific drugs. It's really more the metabolism becoming healthier is making the body healthier.
This goes to show you why the metabolism is so interesting, because it's involved with everything.
Yeah.
Yeah. Wow. Another really exciting edition of Mailbag, Fat Science. If you have a question for any of us, info@diabesity-institute.org. Thank you so much, everyone, for listening and for your questions. They were fantastic. And this has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.